Vomiting is common during pregnancy, but when does it become hyperemesis gravidarum? Hyperemesis is defined as severe persistent nausea and vomiting during pregnancy, not related to meals or just the morning, not responding to standard oral medications. Often requires hospitalization as it can lead to dehydration, weight loss, and even organ damage. So, why does hyperemesis gravidarum happen? The exact cause of hyperemesis gravidarum is not fully understood, but several theories help explain why it occurs. One endocrine theory. This theory suggests that rising levels of pregnancy hormones, especially HCG and estrogen, play a major role. HCG stimulates the vomiting center in the brain. Estrogen delays gastric emptying, worsening nausea and vomiting. This explains why hyperemesis is more common in multifetal pregnancies, more common in vesicular mole. Often improves after the first trimester when HCG levels decline. 2. Vitamin deficiency theory. According to this theory, vitamin deficiencies during pregnancy, especially vitamin B1, thiamine, vitamin B6, pyridoxine. The fact that treatment with these vitamins improves symptoms in many patients supports this theory. 3. Psychological theory. This theory is based on clinical observations that hyperemesis is more common in primigravida, associated with psychological stress and anxiety. In some cases, isolation and reassurance alone can significantly reduce or even stop vomiting, highlighting the role of the brain-gut connection. One-line summary. Hyperemesis gravidarum likely results from a combination of hormonal changes, vitamin deficiencies, and psychological factors rather than a single cause. So why is hyperemesis actually dangerous? If not properly managed, it can cause serious maternal and fetal complications. First, maternal complications. Prolonged vomiting causes thiamine deficiency. This can lead to Wernicke's encephalopathy, which presents with confusion, ataxia, and eye movement problems. Repeated forceful vomiting increases venous pressure. This may cause retinal hemorrhage, and in severe cases, retinal detachment and blindness. Severe malnutrition leads to brown atrophy of the myocardium. This can progress to heart failure. Forceful vomiting causes tears at the gastroesophageal junction. This is known as Mallory-Weiss syndrome and presents with hematemesis. Starvation and hypoxia cause fatty infiltration of the liver with centrilobular necrosis, which may progress to liver failure. Severe dehydration leads to hypovolemia. Reduced renal perfusion causes pre-renal acute kidney failure. Dehydration causes hemoconcentration and viscous blood, and this increasing the risk of venous thromboembolism. We have also metabolic disturbances like electrolyte imbalance, including hyponatremia, hypokalemia, mainly due to renal potassium loss, metabolic alkalosis, due to loss of gastric acid, starvation ketosis due to body shift to fat breakdown for energy, and finally, fetal complications. Reduced placental perfusion may cause spontaneous abortion. Maternal nutritional deficiencies increase the risk of congenital malformations. How to diagnose hyperemesis gravidarum. Clinical picture. There are 3 main features. 1. Vomiting. 2. Dehydration. 3. Evidence of complications. Vomiting has 3 main characteristics, as we said before. Not related to meals, not responding to standard oral medications, often requires hospitalization. Investigations. There is no specific test for hyperemesis, so diagnosis is mainly by excluding other causes. We will do ultrasound. May reveal underlying causes such as vesicular mole or multifetal pregnancy. Laboratory tests. Serum beta HCG as it elevated in vesicular mole. Thyroid function tests for gestational hyperthyroidism. Complete blood count. Coagulation profile. Liver and kidney function tests. In severely complicated cases, MRI to assess for Wernicke's encephalopathy. Fundus examination to detect retinal hemorrhage. echocardiography to evaluate for cardiomyopathy, upper GI endoscopy to detect Mallory-Weiss syndrome. How to manage this case? Initial management. The patient should be hospitalized, isolated, and kept under close observation. Nutritional management. Start with NPO, nothing per oral. Since the patient cannot take oral nutrition, begin intravenous fluid therapy. 1 liter of normal saline plus 20 to 40 millimole of potassium chloride every 8 hours. Avoid dextrose initially as it may worsen Wernicke's encephalopathy. Medications. Administer antiemetic drugs such as cyclizine and promethazine. Possible outcomes. We have 2 possible outcomes. First one, successful response. And if the patient improves, gradually introduce a light oral diet. Avoid fatty and spicy foods. Second one, failure of initial management. If the patient does not respond, start total parenteral nutrition including fluids, electrolytes, and vitamins, plus steroids. If all measures fail and the condition becomes life-threatening, termination of pregnancy may be considered as a last resort.